So, good evening, everyone. Warm greetings from Association of Child Neurology. So, welcome to this third series of AOC and Web Academy series for pediatric postgraduates. We have called it as What is New in What is New Talk and Quiz series in Pediatric Neurology. So, this series has been designed with a motive that we motivate students to read the topic before they come to attend the lecture, and they also attend to the lecture very carefully so that we have a very interesting quiz at the end of the talk. So Dr. Ranjit is the quiz master along with Dr. Ram, who will be conducting the quiz at the end of this talk. So today it is a proud privilege to introduce Dr. Rekha Mittal, ma'am. Ma'am, welcome, ma'am.
Thank you.
So it's a home coming again. So ma'am has worked in army for n number of years and now currently working in Rainbow Hospital in Delhi. Ma'am is a senior pediatric neurologist, and currently she is the president of Association of Child Neurology. And she has taken a lot of active measures, and this active series is also probably secondary to Dr. Rekha ma'am's thinking and thoughts. So hope we all enjoy listening to Dr. Rekha. And today is the most controversial topic, so we handed over this topic to Dr. Rekha, that is what is new in febrile seizure. So I would welcome Dr. Rekha Mittal to share her presentation.
Thank you. Can I start?
Yes, ma'am. I think it's almost 9.
So good evening, everybody. At the outset, thank you, Dr. Kaushik, for inviting me to speak on febrile seizures, what's new. But as we all know, everything new evolves from what is old. So my talk will be an amalgamation of what is new and also what is old. Now, febrile seizures are the most common seizures of childhood, but they have remained mired in confusion and controversy for many years. However, recently there has been some clarity and consensus in some aspects of the febrile seizures. And although this appears to be a small topic, but on Google search, we will find as many as 3.8 million results if we feed in these two words. At the end of my talk, some things will be clear, some will still leave some questions unanswered, and some issues will remain uncovered, which can be clarified during the question answer session at the end of the talk. To start with the definitions and terminology, febrile seizures are seizures occurring in children between the ages of 6 months to 5 years of age and in association with fever greater than 38 degrees centigrade. The child should not have any evidence of an intracranial cause, either an infection, head injury, or epilepsy, or any other definable cause of seizures such as electrolyte imbalance, hypoglycemia, drug use, or drug withdrawal, or a history of an afebrile seizure in the past. It's important to remember that the height of temperature is now thought to be more important than the rate of rise of temperature, which was the thought process some many years back. And some children actually appear to be afebrile at the time of fever, and fever is noted only after the seizure. Some children appear to have seizures even at a lower temperature if only the surface temperature is taken, because it's the core temperature that is more important. This definition has certain drawbacks because it does not exclude children who have a pre-existing neurological deficit, although their investigation and management strategies are different. Febrile seizures can be of two types. About 80% of them are simple febrile seizures, and the rest 20 to 30% are complex febrile seizures. Simple febrile seizures means that the seizures are less than 15 minutes, 10 according to the NHS UK. They are less than 15 minutes duration, have no focal features, and there is only one attack in one febrile episode or within 24 hours. Complex febrile seizures, on the other hand, are more than 15 minutes in duration, and they have some focal features. They could be focal at onset, focal throughout the seizures, or they may appear to be generalized, but after the seizure is over, there is Todd's paralysis, which indicates that the seizure was probably focal in origin. And if there is more than one attack in one febrile episode or in 24 hours. However, remember that seizure duration may often be difficult to identify because the parent's perception of the duration can also be very inaccurate, especially in times of stress, and an indirect evidence for the duration of seizure has to be sought, such as how long did it take you to go from one room to the other, how long were you trying to shake the child, and things like that. Also, if treatment is given before the seizure ends at 5 minutes, then also the actual duration of seizure may be difficult to guess. Now, febrile seizures plus is a condition where febrile seizures continue past the usual age where they are expected to resolve. That is 5 years of age, or they are accompanied by afebrile generalized seizures of different kinds, or even focal seizures. Then GEFS plus is a syndrome which has come to light or been defined in the last few years. It is a familial epilepsy syndrome in which the child has a history of febrile seizures plus, and the family members have a history of a variety of epilepsy phenotypes. The most common is febrile seizures and febrile seizures plus, and the most severe phenotype is the Dravet syndrome and the myoclonic atonic epilepsy. Now, here's a confusion. Febrile status epilepticus. Now, if we were to use the definition of the ILAE, where two time periods are defined, T1 and T2, where T1 is the time period after the seizure is unlikely to stop by itself and is equal to 5 minutes for generalized seizures and 10 minutes for focal seizures, and T2 being the time period after which there is likely to be some neurological damage and is equal to 30 minutes. In that case, how would we define simple and complex febrile seizures? So there is some bit of confusion over here. Operationally, any child who is brought to the hospital with ongoing seizure will be called febrile status epilepticus. But how far we can use this classification is not clear. In 2014, there was a study of febrile status epilepticus where a duration of 30 minutes for calling a febrile seizure as febrile status epilepticus was used. And for the present, I think we should use this definition. Now, the demographics haven't really changed over the years. In India, approximately 5 to 10% of all children less than 5 years of age would have febrile seizures, which is somewhat higher than in the West. Males are more affected, and it is more common in the lower socioeconomic status. Some seasonal variation may be there, which has been reported in Western countries, but is not been documented in India. Most of the, approximately 60% of the children would have their first attack within 2 years of age, and the rest later on. And there is a family history of febrile seizures in 25 to 40% of the children. And the risk of febrile seizures in any child depends upon who the affected family members are. And if one parent and one sib is affected, there is a 50% chance that the child is going to have febrile seizures. The pathophysiology is largely unknown, but a lot of work has been done recently in why febrile seizures occurs. We can divide it into two parts, the risk factors and the triggering factors. Now, the risk factors are actually the young brain or the child's brain has a higher susceptibility of having seizures. In addition, there is a genetic susceptibility to have febrile seizures, and recently iron deficiency, anemia, and almost all elements like calcium, sodium, whatever, you name it, deficiency of these substances have been said to be implicated. However, none of them have been proven to actually be causing febrile seizures. We need to talk more about the genetic susceptibility. Now, this condition is genetically complex, and it's an extremely heterogeneous group. There is no single mode of inheritance, but many people think that it is autosomal dominant with a variable penetration, or it could also be polygenic with multifactorial transmission. Approximately, or rather 10 febrile seizure susceptibility foci have been identified from Feb 1 to Feb 10, and it's a long list, and the number is actually increasing. But remember that the causative gene has not been identified in most of the patients with febrile seizures. In the GEFS plus syndrome, mutations have been found in the voltage-gated sodium channel genes such as SCN1A, 1B, GABA receptor subunit genes, and the PCDH19 gene on the X chromosome. In some studies, the interleukin 6 gene, 174GG, is found to be significantly in higher numbers of children with a family history of febrile seizures. So what triggers the seizures during a fever? Two theories have been postulated. One is that during fever, there is hyperventilation, and therefore there is alkalosis, and we all know that alkalosis can precipitate seizures in many people. The other more plausible theory is that the infection results in release of cytokines such as interleukin 1B, interleukin and 1/6. These are which ultimately result in seizures. This is a beautiful diagram which explains how seizures, how these two, the risk factors and the triggering factors interact. On the right side, you can see that there are the mutations like GABA receptor mutation, sodium channel mutation, and the interleukin mutations increase the risk of febrile seizures. And then there is an infection which causes synthesis of interleukin 1 beta in the hippocampus, and it also causes fever, and all these are interrelated. Sometimes exogenous elevated brain temperature such as a hot bath can also be implicated. When these two come together, the elevated temperature impacts the ion channels, increases glutamate and decreases GABA. There is increase in excitability, and a simple febrile seizure can result. However, the factors for complex febrile seizures are not so well defined. The type of infection is usually a viral infection, but any infection that causes fever can result in febrile seizures. Vaccines have also been implicated, especially DPT and measles and MMR, but almost any vaccine which causes fever can cause febrile seizures. The types of seizures in febrile seizures could be generalized tonic, clonic, or tonic-clonic, focal seizures, or even just a brief period of hypotonia, but they're always associated with the loss of consciousness. The seizures during febrile seizures are never myoclonal. Therefore, if myoclonus occurs, one should think of febrile myoclonus, which is a benign condition, which may get unnecessarily over-investigated. Also remember that seizures in febrile seizures usually always occur on day 1 of the fever. Other events during fever which may be mistaken for seizures are rigors, delirium, syncopal attacks, febrile myoclonus, sometimes breath holding spells, and even vertigo. Therefore, history taking is extremely important. Then coming to management. Once upon a time, seizures with fever were equal to meningitis, which was equal to LP in all cases. So way back in the 80s, this is what used to happen. And if the CSF came out to be normal, then even febrile seizures were treated as a seizure disorder and treated like epilepsy. And most kids would end up getting phenobarbital for 2 years because in those days, valproate was not easily available. However, lately there is consensus on many aspects or some aspects of management of simple febrile seizures. There are, however, no well-defined guidelines on the management of complex febrile seizures, and management is often individualized and based on clinical decisions. Whenever a child presents with the first febrile seizures, the management is three-pronged. It consists of the immediate management, the neurodiagnostic evaluation, and the counseling at the end of the admission if the child has been admitted. So firstly, the immediate management. If the child comes seizing to the hospital, the management is no different from any other acute seizure management, that is airway, breathing, circulation, and the anti-epileptic drugs, and prolonged febrile seizures must be treated as status epilepticus. If the child comes to the emergency and is not actively seizing, please do not give a benzodiazepine or load with phenytoin or any other anti-epileptic drug. Then mostly the child has high fever, so tepid sponging should be avoided, which this is something that is commonly done. As soon as the child with febrile seizures comes, the staff immediately starts some sort of hydrotherapy, but this should not be done because this can cause vasoconstriction and actually cause a rise in the core temperature. Antipyretics may be given like paracetamol or whatever brings down the fever, whatever you're comfortable with. But remember that bringing down the temperature does not actually control the seizure and also does not prevent further seizures occurring during the febrile episode. Then neurodiagnostic evaluation. So history is very important. Most people in the casualty will take a very good history of the fever and temperature, the causes of fever, and the relationship of the seizure onset to the fever onset. But the rest of the history is very sketchy. So I would like to emphasize that history should include seizure semiology, what the postictal status was, past history, antenatal, perinatal history, developmental status, febrile seizures, and extremely importantly, the immunization history and the administration of antibiotics, because this will help us in deciding the further neurodiagnostic evaluation. Clinical examination in detail, especially the CNS, must also be done. Then basis that the investigations follow 4 types of investigations: the lumbar puncture, other investigations, the EEG, and the neuroimaging. So here it differs on whether the child has simple febrile seizures or complex febrile seizures. In case of simple febrile seizures, what should an LP be done? So way back in 1996, the American Academy of Pediatrics recommended that all children less than 12 months of age needed to undergo an LP. If they were 12 to 18 months of age, observation by at least one senior experienced doctor was required for decision making, and more than 18 months, the LP could be withheld if there were no indicators of meningitis. And this is what we all used to follow for many, many years. However, many studies came along and it was actually found that in cases of apparent simple febrile seizures, bacterial meningitis was found in only about 0.2% of the cases, and in apparent complex febrile seizures, it was 0.6%. Therefore, the utility of routine LP for diagnosis of CNS infections with an apparent first febrile seizure was low. And if the child came with simple febrile seizures, one would have to do more than 1100 LPs to identify one case of meningitis, and this number would be 180 LPs in case of complex febrile seizures to identify one case of meningitis. Therefore, the guidelines were revised, and in 2011, the American Academy of Pediatrics brought out the clinical practice guidelines for the neurodiagnostic evaluation of a child with simple febrile seizures. Now, what is this guideline? They recommend the recommendations for, these are the recommendations for evaluation of children 6 to 16 months of age who present with simple febrile seizures within 12 hours of the events, and it is not applicable to children who come with complex febrile seizures or previous neurological insults, known CNS abnormalities, or history of afebrile seizures. So any child with simple febrile seizure, coming at any age, and there are features of CNS infection on history and clinical examination, such as drowsiness, lethargy, irritability, or an abnormal neurological examination, lumbar puncture must be done. In any age, if there is a pre-treatment with systemic antibiotics by any route given within the preceding few days before the seizure occurs, then lumbar puncture is an option, which means that you are free to take a decision depending upon the clinical status of the child. And this is because antibiotic treatment can mask the signs and symptoms of meningitis. Some facts to consider could be which antibiotic was administered, the dose, route, CSF penetration, and etc. However, if an infant comes between 6 and 12 months and is deficient in Hib and pneumococcal immunizations, or if the immunization status cannot be determined, then these could also be candidates for lumbar puncture, and this could be optional. The decision is left to the clinician. However, if children are older than 12 months come with a vague history of immunization or non-immunized status, the lumbar puncture is not required because clinicians would require the symptoms of meningitis. Then other investigations are not performed routinely only for febrile seizures. EEG, about 30 to 40% patients would show paroxysmal abnormality, but an abnormal EEG does not change the management of simple febrile seizures, and therefore it is not required for the management of febrile seizures and not indicated. Neuroimaging is not performed in routine evaluation of a child with simple febrile seizures. Coming to complex febrile seizures, there are no specific guidelines and clinical judgment is used in most cases. So first, the LP. In a 13-year study in a tertiary children's hospital of 526 previously healthy children, only 3 patients had bacterial meningitis, and out of these, 2 had clinical findings suggestive of meningitis, and the 1 child who didn't was presumed to have meningitis only because an organism was grown in blood culture. Another study, which was much larger, was conducted in the USA, in which 28,810 children visits for complex febrile seizures were analyzed. It was found that LP was performed in more than 7,000 children, and the findings were amazing. Overall, CNS infection was diagnosed in only 80, which is quite similar to simple febrile seizures. Also, it was found, interestingly, in the study that at the start of the study in 2007, LPs were performed in 31% of the cases. But by the time the study ended, I think people had learned that probably LP is not going to be useful. So LP was performed only in 17.8% of the cases. Therefore, if we look back, we will see that in 1991, the working group of the Royal College of Physicians in UK had recommended that LP should be done for all cases of complex febrile seizures. But in 2003 and later in 2009, a decision has been made that LP, even in complex febrile seizures, should only be done in those children who have signs of meningitis. Thus, we find that the criteria for doing an LP in complex febrile seizures are somewhat the same as for simple febrile seizures. However, the clinicians are free to take a decision at all ages, and if the child remains well and returns to baseline after the seizure is controlled, LP may be delayed, but the child must be observed for at least 24 hours if required. Other investigations, one may be a little more aggressive. Blood sugar counts may be done to evaluate cause of fever, blood sugar, and biochemical tests may be done where the underlying illness may be contributing to a biochemical abnormality. What about EEG? So the occurrence of EEG abnormalities after complex febrile seizures is widely variable, and there is no febrile seizure specific EEG finding. Predictors of an abnormal EEG would be age less than 3 years, EEG within 7 days of complex febrile seizures, and an abnormal neurological examination. In 2017, a Cochrane systematic review showed that there was actually no RCT to refute or support the use of EEG, and neither was its timing clear after complex febrile seizures. Practically, what most people would do is, if there is a family history of EEG, of epilepsy, and EEG may be done, but it may not change the management of febrile seizures. However, it may help in prognostication. In cases of febrile status epilepticus, an EEG should be done. Then neuroimaging. A whole lot of studies have been done which have shown that whatever MRI abnormalities are picked up on imaging, none of them have contributed to change the immediate management of the febrile seizure. And therefore, neuroimaging is not indicated urgently. Many times I have found that whenever a child is admitted with febrile seizure and he is to be sent to the ICU, the instructions are, please stop on the way to the in the radiology department and get a CT done. Now, this is a wrong practice. There is no need for any emergency neuroimaging. Moreover, CT scan has absolutely no role. A recent recommendation is that if there are focal features or the seizures are prolonged, MRI may be done. And some findings that may be noted are the mesial temporal sclerosis, some focal hyperintensities which are subcortical, abnormal white matter signals, or even focal cortical dysplasia. So this is a summary which shows basically that in simple febrile seizures and complex febrile seizures, indications of LP are somewhat similar, but in simple febrile seizures, no other investigation is required. However, in complex febrile seizures, a clinical decision can be taken regarding the other investigations. The EEG would depend upon whether there's a family history or not, and neuroimaging, whether there are focal features or not. But overall, in complex febrile seizures, there are no guidelines. In all cases, if no LP is done, an observation of the child is required. Some people say 8 to 12 hours, but for complex febrile seizures, up to 24 hours. In all cases, remember to treat the cause of fever. So when do we hospitalize these children? After a first febrile seizure, if the age is less than 1 year, GCS less than 15, 1 hour after the seizure, any complex febrile seizure, any indication of lumbar puncture, and also if the child's home is very far away from a medical facility, or the parents are confused and very apprehensive and seeing that they will not be able to cope with the febrile seizure recurrence at home, the child can be admitted. Then coming to counseling. So the most important thing, especially in simple febrile seizures, is to reassure the parents. Mostly they have to be told that these are benign conditions and they would probably go away by the age of 5 years. However, this is not to say that the risks of febrile seizures are not to be explained. All risks of febrile seizures in the future have to be explained, and these include risk of recurrence, risk of epilepsy, risk of MTS, mental and neurological deficit, and mortality. So what is the risk of recurrence? As many as 35% of the children will have recurrence of febrile seizures after the first febrile seizure, and most of these would occur within 12 months of occurrence of the first febrile seizure. There are certain risk factors for recurrence, and of these, the most important is the age of onset less than 12 months, a family history of febrile seizures, not of epilepsy, febrile seizures with low fever, or a short duration between fever onset and febrile seizures. Some people, however, include family history of epilepsy also as a possible risk factor. Complex febrile seizures, neurodevelopmental abnormality, sex and ethnicity are not actually risk factors for recurrence. Then what is the risk of epilepsy in febrile seizures? So the risk factors for complex febrile for epilepsy is complex febrile seizures, a family history of epilepsy, and developmental or neurological abnormalities before a first seizure. So the overall risk of epilepsy is 2 to 5%. But if there is only one risk, if there is no risk factors as listed in the previous slide, it is 1%. If there's one risk factor, 2%. And if more than 2 risk factors, it's 10%. That means that in all children with febrile seizures, 90% of the children will never develop epilepsy. Then what about mesial temporal sclerosis? A lot of study and has been carried out in this area in the last few years. Whether prolonged seizures cause hippocampal sclerosis and TLE has been debated for many years. Still, the incidence of MTS and febrile seizures is only 1 in 75,000 children. An important study which was done was called the FEBSTAT study, Febrile Status Epilepticus study, the results which were published in 2014. In that, it was found that 226 children between 1 and 6 years of age with febrile status epilepticus, 22, that is about 10% only, had T2 hyperintensities in the hippocampus soon after the seizures, and out of these 22, 10 developed hippocampal sclerosis and 12 had reduced hippocampal volume on follow-up. That means that is a clear association between mesial temporal sclerosis and febrile status epilepticus. Then mental and neurological deficit. Mostly if the child is neurologically normal before the onset of febrile seizures, he will remain normal. But there is a small risk of deficit of hemiplegia after the seizure, after febrile seizures has been reported, but it is thought that probably the hemiplegia pre-existed and it was noted only because a febrile seizure occurred on that site. Children with febrile seizures are noted to have a higher incidence of ASD, learning difficulties, and some developmental and ADHD disorders. What about mortality? So only occasional cases are reported, and earlier we used to say that hardly febrile seizures hardly causes any deaths. But there are some recent studies which has found that complex febrile seizures and febrile status epilepticus may be associated with SUDEP. In some studies, in one study in Denmark, 245 cases with sudden cardiac death, it was found that 14 of them had been admitted with febrile seizures, and therefore it is presumed that some febrile seizures could be a risk for sudden cardiac death. And this fact parents should be counseled that yes, there is a small risk of mortality even with febrile seizures. Then all parents must be counseled about pre-hospital seizure management, and I will deal with this later on. So what is the long-term management? In long-term management, we have to decide and tell the parents about the fever management, the seizure management as it occurs, and what can be done to prevent recurrences, and should we prevent recurrences. So management of fever involves giving suitable antipyretics, whatever works. These will increase the comfort of the patient, but will not prevent a recurrence. And parents must be told that it is not enough to bring down the fever whenever it occurs in the future. Every fever episode, you have to find and treat the cause of fever. What about seizure management whenever it occurs? So the management of febrile seizure recurrence is an important part of counseling. All parents must be taught about home seizure or pre-hospital management. This can be done by parents, paramedics, primary physicians, school teachers, whatever. They have to be told that whenever a seizure occurs, put the child on the side. Nothing is to be put in the mouth. Time and video record the seizure. In case the seizure does not stop in 3 minutes, midazolam nasal spray 0.5 milligram per kg is to be sprayed in the nose, and the proper procedure is to be demonstrated. I once had a patient who said my child's seizure does not stop when I give midazolam. So I asked her to show how are you giving it. So I found that she was actually not removing the nozzle before giving the spray. So one has to actually demonstrate the procedure properly. You can record it on a video and show it to the patient every time you are counseling them. If the seizure in future occurs in hospital, then the management is as for any other seizures. Then prevention of recurrences. This could be done by two ways. One is intermittent prophylaxis and the second is continuous prophylaxis. Intermittent prophylaxis means that in all febrile episodes, you give a fast-acting and benzodiazepine. Usually, diazepam used to be given earlier in olden days, but we found that actually acceptance of rectal diazepam was not good, and I hardly had any patients who would actually give it. Some oral diazepam could also be used, and it was more acceptable. Clobazam is a good drug in a dose of 1 milligram per kg. Both of these could be given for 2 to 3 days and are successful in preventing recurrences in 80 to 90% of the cases. Recently, there have some studies which show that intermittent levetiracetam may also be useful, and this can be used if one feels that close observation of the neurological status is required, but levetiracetam needs to be studied more before it can be recommended routinely. Then continuous prophylaxis. This is now no longer recommended routinely for preventing recurrences of febrile seizures. The two useful drugs are phenobarbital and valproate, and of late levetiracetam and topiramate have also been used. They may be effective, but more studies are needed before they can be recommended. However, for the long-term management of febrile seizures, in 2008, again, the American Academy of Pediatrics came out with the guidelines. They studied the risks and benefits of both these methods of preventing recurrences and said that neither continuous nor intermittent anticonvulsant therapy is recommended for children with one or more simple febrile seizures. Only home seizure management is to be explained to the parents. But in case of complex febrile seizures, there are no real guidelines. Home management of seizures has to be explained and is the same as for simple febrile seizures. But intermittent benzodiazepine prophylaxis can be given during future episodes of fever, especially if the febrile seizures were prolonged. Long-term AEDs may be given in exceptional circumstances only. So here, one important point that I want to make is that no treatment alters the risk of epilepsy. So there is no justification for giving any of these therapies saying that, okay, we'll give this treatment, the child will not have epilepsy in the future. Which cases should be tested genetically? If the seizures are recurrent and prolonged febrile seizures, febrile status epilepticus or GEFS plus, one can take a decision to do some genetic tests, or if there are neurodevelopmental disorders associated for which cause is not known, or there are any dysmorphic features. When should a neurologist be consulted? If the first seizure is a complex febrile seizure and there is an abnormal neurological exam, abnormal neurodevelopment, and if one is not sure or has some doubt about anything, or if you feel that you're not confident of managing, please consult a neurologist. So to summarize, the overall management in case of a first febrile seizure, the important thing to do is control the seizure, control the fever, rule out CNS infection, find and treat cause of fever, counsel parents and teach them home seizure management. If after the first seizure there are no recurrences, no treatment is required. If there are few recurrences of simple and complex febrile seizures, home management of febrile seizures is advised. But if there are prolonged multiple recurrences with several risk factors, age less than 1 year, with some difficulty in home seizure management, or a medical center is not close by, or there is severe parental anxiety, then intermittent benzodiazepine prophylaxis may be advised. But if despite giving this, there are continued severe prolonged recurrences with low temperature at onset of fevers, or there is a short interval between the onset of fever and onset of seizure, only then continuous anti-epileptic prophylaxis may be given, but these cases are actually really very few. So to summarize what's new, the genetics of febrile seizures plus and GEFS plus, and their recognition as specific syndrome, triggering factors in febrile seizures, guidelines for neurodiagnostic evaluation of simple febrile seizures, Emerging agreement on neurodiagnostic evaluation of complex febrile seizures, guidelines for long-term management of simple febrile seizures, association of febrile status epilepticus with hippocampal sclerosis or hypoplasia, and importance of early control of seizures, pre-hospital seizure management to be emphasized and taught to the parents, and newer drugs for intermittent and continuous prophylaxis. So lots of new stuff going on. Thank you.
Thank you so much, ma'am. It was an excellent talk, and I'm sure all the attendees benefited a lot. It was a very, very quick and a very concise talk, which had all the information which is required. And those students who have listened very carefully to your talk will be able to crack the quiz a lot. So now I welcome Dr. Ranjit and Dr. Ram, who are the quiz masters, to please conduct the quiz, give the instruction to the attendees, and once the quiz time is over, we will take up the questions. Over to you, Ranjit.
Can you please enable the screen sharing, sir? Yeah.
Okay.
Can you see my screen, sir?
Yes, Ranjit, please.
Good evening, everybody. Good evening, Rekha ma'am, for such a wonderful talk. So welcome to the second series of quiz. So I will give the instruction to the participants. Open your Kahoot in mobile app, laptop, or in computer. Create a unique nickname for you. We know the character limit is 15. There is a small change from the previous quiz. Here, you write the first 5 letters of your first name, followed by your mobile number. For example, my name is Ranjit Kumar, so I have written RANJI, then my mobile number. That makes it 15 digits, 15 letters, and this will help us in identifying the winners. So I request pediatric neurologists not to participate. If any qualified or trainee pediatric neurologist wants to participate out of interest, they can enter their nickname as Neuro followed by their mobile number, like as shown here. They will not be considered for prize. It's a self-paced challenge. The participant has to select the next icon after answering a question to proceed to the next question. It won't move automatically. You have to select the next option. Remember, it's not only the number of correct responses which you give will make you score high. Faster you answer, higher you score. So note it to get a higher score. Each question is time bound, countdown is indicated. And also, if you don't want music, you can disable yourself. Winners will be announced at the end of the quiz, and the quiz master's decision will be final. So I am going to post the link of the quiz to all the attendees. Yeah. So this is a link. You can press and proceed. I am also giving game pin for those who
So for those who have joined through the app, please press the link game pin as 05239931.
So can you see this? Can you see the screen, sir?
Yes, Ranjit. Yes.
So the quiz has started now.
Very good, great. So we want students to start answering fast.
As of now, 14 players have joined.
Great. So we should encourage all of them to join. Even if you're a pediatric neurologist, write neuro and then join. The game pin, I'm repeating, is 05239931. It's very interesting quiz. Please join the quiz.
So right now 60 people have joined, 60 participants have joined.
Great, great. So we have around 100 more. So I would encourage others to also join.
Maybe in another 2-3 minutes, we'll get some early trends.
Great, great. So this is a short quiz for only 10 minutes. So please be very fast in answering. So good to see now. I think 75 people have joined. I just wanted to remind that just in case you're a pediatric neurologist, just enter your nickname as Neuro followed by your mobile number.
So we have some early trends. It seems Pradeep is leading.
That's good to know. Let's see who wins the game.
Followed by Harshi, followed by Shush. So we have a total of 20 questions this time. So at this moment, it seems the participants are almost halfway through the quiz.
Very good, very good. So people should be very fast, because the more faster you are, the higher the chances that you will win the game, provided the answers are correct.
So now Shush is leading, Pradeep is trailing, Anwar is the runner, in second place, Jaya is in third place.
Good to know that nearly 100 people have joined. It's good to see the spirit of the students. Wonderful.
Shanjit, do you have info about how many questions have they finished? To what stage we are in?
Yeah,
if you have, I think they say questions
average,
completed.
On an average, I could see 10, 11 unanswered. So 50% they have crossed. So 10
Very good.
Yeah.
Very good, all candidates. You come to the halfway mark. Okay, keep going. Good job.
By the way, this is Dr. Ram.
Thanks for the introduction.
Yeah, because so Shush is steadily leading on the first place. Anwar is second. Jaya, let's see. Yeah.
Ranjit, there are few who have not been able to join. So please go to Kahoot app and write the game pin as 05239931. Please open Kahoot app and write 05239931. If you do not have the app, please write kahoot.it in your web browser and join with this game pin.
Now it has crossed 105. 105 participants are in. Yeah. So now there is a pediatric neurologist, it seems, who is leading. So he has rightly entered his name as Neuro nickname. So
all candidates, do not lose hope. It's only halfway through. You don't know. Some of these toppers might get a few questions wrong. And then if you get 5 continuously correct, your mark jumps up. Okay. So don't lose hope. Tackle every question as it is. And just try to get that answer correct. Okay.
I'm repeating for those who have joined late. The game pin for Kahoot is 05239931. 05239931.
Now, two neuro-pediatric neurologists are leading. It seems the non-trainee is, second runner-up is Black Panther. Nilad in 4th place, Rahul in 6th place.
Ram, how much time is left?
1 second.
From the time we posted,
Yeah, you have about 2 minutes left.
Oh, please be very fast. Only 2 minutes are left. I would request all of them to please.
Yeah, 2 minutes is challenge closes. Okay, so everyone as fast you can. Okay.
So we have now 113 participants who have joined. Yeah, few of the participants have finished their finished.
Okay, we'll leave it open for a few more minutes. I'll tell you the time of closing.
Yeah,
we have a little bit more time.
So now Neuro followed by Arun is leading. He has just one unanswered. Let's see.
Can request participants who have finished not to go back and answer the ones which sometimes the app does give an option. Let's not go back and try again. Okay. I know you won't, but just that there is an option that falls in the app.
So we have a minute more maximum.
Most of them have finished. Yeah, it seems.
Okay.
Most of them have finished.
We can stop.
To end the...
we can stop. We can stop now.
Or shall we give 30 seconds?
I think you can give about 20 seconds and then we can hold. I think how many have finished? How many have you seen who have finished?
Many. See, 114 participants are there, and
107 haven't finished. Only 7 have finished.
Yeah, 7 have finished.
Okay.
Okay. So once it is entered, Ranjit, can you stop share your screen?
No, sir.
Are we done?
Do you want to stop share now?
Yes, yes. So that we can take up the questions and then you tell the right answer and the prize winner.
Yeah. So I have stopped sharing.
Thank you.
So with your permission, shall I end it now?
Yes, yes, please.
Okay. So I'm giving last 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay, close.
Yeah.
Thank you, Ranjit and Dr. Ram. Dr. Rekha, ma'am, there are many questions which are waiting for you. Hello.
Hello. Yeah, I'm there.
Yes, ma'am. So Dr. Rakesh had sent the greetings from Agra and he has asked the first question. Has ILI redefined the lower age for febrile seizures?
No.
Okay. Dr. Jitangi has asked that though this exploratory comparison was neither statistically significant nor adequately powered.
Which one? Sorry?
I think the question seems to be incomplete. I think we can ask him to repost the question. Okay. So if a 2-month-old infant has a seizure that has been triggered by the fever in absence of CNS infection and other provocating factors, do we call it as a febrile seizure?
So if we are going to go by the most commonly used definition, then it is not classified as a febrile seizure.
Okay. Can a neonate have a febrile seizure, ma'am? And can you highlight a little more on that?
Yeah. So actually to this thing, Dr. Bhatia's question, the ILA says 1 month. Some bodies are using a timeline the lower age limit as 1 month. But if a newborn has a seizure with fever, definitely we will not call it febrile seizure. We would investigate it as something else, maybe an infection or a fever-provoked seizure, something else. But it would not fall within the definition of febrile seizure.
Okay. Ma'am, there is another interesting question. What are the indications of continuous anti-epileptic prophylaxis in febrile seizure? I think you have mentioned it. Can you summarize?
In the summary of management. It would be those children who are having very frequent prolonged seizures. So we know that if there are prolonged febrile seizures or even febrile status epilepticus, and these are recurring, and the duration between the onset of fever and onset of seizure is very short, in those cases one would like to give continuous prophylaxis, because there even clobazam will not work. By the time you notice that the child has fever and the seizure would have occurred, and so even clobazam will not have the time to be effective, and in those cases only continuous prophylaxis may be given.
Okay. Ma'am, what is the management? What is your take on management of febrile status epilepticus in Dravet?
Febrile status. So all febrile. So in Dravet we try to avoid phenytoin, right? So in those cases, valproate would be a better choice. After initial benzodiazepine, valproate would be a better choice in Dravet syndrome for a loading dose.
Okay, another controversial question is whether the recurrent febrile seizure within 24 hours will be classified as complex febrile seizure, or do you want to call it as simple febrile seizure plus?
So simple febrile seizure plus is a term which is used somewhere in some places, but simple febrile seizures plus, according to those people who like to use that term, behave in the long term like simple febrile seizures only. However, most people currently use multiple seizures within 24 hours or in a simple or in a single febrile episode as complex febrile seizures.
Okay. Ma'am, what is your take on management of febrile seizure in patients with cerebral palsy?
So, as I said, this issue is kind of controversial because the definition of febrile seizure doesn't exclude these children. So, in children who have cerebral palsy or any other pre-existing neurological deficit, as I told you before, the risk of epilepsy is higher, but the risk of recurrence may not be. It is not a risk. It is not a factor for risk of recurrence. So, in a first episode, if it behaves like a simple febrile seizure, I would prefer to wait and see what happens. If the child has at any future time develops afebrile seizures, then of course one will have to treat it as epilepsy. However, if the child continues to have only brief simple febrile seizures, in future we would treat it like simple febrile seizures only. Would not like to start long-term prophylaxis in these cases.
Okay. Ma'am, two common questions about a quick note on intermittent prophylaxis indication. And can we start anti-epileptic drug when there are frequent complex febrile seizures?
Yeah, so if there are frequent complex febrile seizures which are really prolonged, like I said, intermittent prophylaxis is effective if it's going to give you time. Intermittent prophylaxis is also given when there are prolonged seizures, complex febrile seizures. And if can I just project my slide again, if you don't mind?
Yes, ma'am. Yes.
So this, I think, if we can just go back to that slide, it will answer almost all the questions. Does this answer the question? So if intermittent benzodiazepine prophylaxis is given if there are prolonged multiple recurrences with several risk factors, age less than 1 year, and the parents are not able to manage at home. Medical center is not close by, severe parental anxiety. In these cases, we will give benzodiazepine intermittent prophylaxis. But if despite this, there are prolonged recurrences and the seizure is occurring at a low temperature, or there is a very short duration between the onset of fever and the onset of seizure, so that there is no time for the clobazam that you have given to take effect, only then we will give continuous anti-epileptic prophylaxis.
Ma'am, there is another question on, is melatonin helpful in prevention of recurrence?
I have not heard about it.
Okay. Would you recommend prophylaxis for the child with Dravet syndrome?
Initially, we would like to try clobazam prophylaxis, but eventually these children start to have afebrile seizures as well, and therefore they would end up getting continuous anti-epileptic drugs.
Okay. If a child comes to you with febrile status for the first time and we have anti-epileptic drug given for aborting it, do we need to continue it?
No. Even in febrile status epilepticus, we should not, until and unless we find very significant EEG changes or MRI changes.
Okay. If febrile status epilepticus, what will be your drug of choice? Levetiracetam or valproate? Is valproate preferred over levetiracetam?
Well, there are no real, I would prefer to use valproate.
Okay. Is buccal midazolam an option for aborting the drug, ma'am?
Yes, it is. Okay. Some people, in fact, use the midazolam nasal spray and actually put it in, give it buccally.
Okay. There is another interesting question, that if the child is more than 6 years of age who presents to you with febrile status, but is neurologically normal, MRI and EEG, both of them are normal, do you recommend giving anti-epileptic drug? If yes, for how long?
No. If it's only a febrile seizure, if it's just this child would fall into the category of febrile seizure plus, I would not recommend continuous anti-epileptic drugs for this child.
Okay. There is another question, that if the patient had a past history of febrile seizures since 1.5 years of age, managed with intermittent prophylaxis, and has been symptom-free for 2 years, and later at an age of 6 years, he develops another fever and seizure. So how do you approach this child?
As long as the child is having a fever with seizures, intermittent, I mean, the management would be the same. However, there can be some problem when these children start going to school, because if they start having seizures in school, they can injure themselves. So the advice to be given to the parents is this, that if the child is pretty much independent in school, partaking of activities which can cause injury if a seizure occurs, in those cases, whenever the child has fever, he should not be sent to school. But if their parents are sending them to school, intermittent clobazam prophylaxis may be given. Long-term anti-epileptic drugs should only be given if the children develop epilepsy, which means unprovoked seizures.
Okay, there is another interesting question, that how can we differentiate a seizure, that the seizure in a child with a global developmental delay is that because of a febrile seizure or some other cause presenting with the fever?
So, firstly, one has to take a history in detail. So if it is, because the children with developmental delays and all, their behavior is completely different. If they have a seizure, even if it is with fever, their workup would be different. We would do an MRI in these cases. We would do an EEG. And the further management would depend upon other investigations that we do. We may need to do a metabolic workup. So the workup and management of these children would be completely different, and is a whole a complete chapter in itself. And if I'm given a chance to talk on it next time, then we'll discuss that.
Okay. Ma'am, is there any role of topiramate in recurrent seizures?
Like I said, I read a couple of studies where people have tried topiramate instead of valproate or phenobarbital for continuous anti-epileptic prophylaxis, but these are just stray reports. This is not a recommendation.
I think another question which comes from the last lecture also, that if a child develops febrile seizure after DPT vaccination, what should be done for subsequent doses of DPT?
So firstly, either if acellular pertussis vaccine can be given, then that would be preferable. But if not, then DT can be given, and parents should be counseled that the child may have a febrile seizure.
Okay, ma'am, there is another.
Stop the, you do not discontinue the vaccination.
Okay. What age would you consider to be the upper limit to call it as febrile seizure? Like FS plus.
FS plus?
Rather, to call it as febrile seizure, the question is about the upper age.
Upper age, I would take it as 60 months, but we used to have a big problem before this definition of febrile seizures plus came along, because then we used to not know what to make of these children. There are some children who keep having only seizures with fever till 9 years, 10 years, 12 years, and they're completely normal otherwise, and they never have any other seizure type. So now we are very comfortable and we can call them febrile seizures plus. Now, if these children have a family history of different types of seizure phenotypes, then we would call it a GEFS plus syndrome.
Okay, ma'am, there is another question on how to differentiate vaccine-induced febrile seizures.
If it is associated with a vaccine, then it is a vaccine-induced febrile seizures. The semiology is the same. There is no difference between the semiology of vaccine-induced febrile seizures or any other febrile seizures.
Okay, I think you have already answered this question. Can a patient present with simple febrile seizure after 6 years?
Yes, but it would not be called a febrile seizure. It would be called a febrile seizure plus.
Okay, so what would be your drug for GEFS plus and how long do you want to treat it?
The management of GEFS plus is like for any other epilepsy, except that we try in GEFS plus, especially in the SCN1A group, we would like to avoid the use of phenytoin and carbamazepine.
Okay,
rest
ma'am.
Everything is management is like for any other epilepsy.
The last question on clarification on fires.
So fires is nobody. Actually, again, it's a kind of a refractory status epilepticus, which is associated with any febrile illness, with some febrile illnesses, and it's very difficult to manage, and often goes on to super refractory status, and multiple drugs have to be tried. You first go with very often general anesthesia is required. The seizures may go on for days or months, and IVIG, steroids, ketogenic diet, everything has been tried. But the outcome is usually not good. They are typically left with either long-term epilepsy or significant neurological sequelae.
One last quick comment on iron and febrile seizure relation.
Yeah. So, like I said, iron deficiency anemia has been implicated as a risk factor for febrile seizures. But some studies say that actually children with iron deficiency anemia have less of a risk of febrile seizures. So like I said, other than the known risk factors which have definitely been noted, all others require further studies and validation and cause and effect relationship studies.
Okay, the last question on, have you experienced NCSC as the as a presentation in febrile seizure, non-convulsive status epilepticus?
Actually, no. I have not seen a case like that.
Okay, great. So there are many messages of congratulations for your excellent presentation from many attendees. There are few questions which are very focused on vaccination. So I would request the audience to please visit the AOCN website and listen to Dr. Rakesh Bhatia's last talk on vaccine-related neurological symptoms. So I think it was a great talk, ma'am. Thank you very much.
Thank you. Thank you, Dr. Kaushik. And thank you, Dr. Ranjit. But can we just have quickly what the questions were and the answers?
Yes, now it is time for handing over to Ranjit. So Ranjit will first give the answers and then finally the winners.
Yeah, shall I share the screen?
Yes,
yeah,
Ranjit.
Please.
Can you see the screen?
Yes, yes, Ranjit.
Yeah. So this may not be in the order which the participants have answered. So which of the following does not preclude a diagnosis of febrile seizure? Age less than 6 months, history of febrile seizure in the past, temperature less than 38 degrees Celsius. So this does not preclude this thing. History of febrile seizure in the past is the answer. 10-month-old typically developing baby presented with fever and brief repetitive shock-like jerks, primarily involving upper limbs, occurring for few minutes repeatedly over 1 hour. There was no loss of consciousness. This is febrile myoclonus. Name the epileptologist to whom this quote is attributed. So long back itself, they have made a kind of distinction between simple and complex. In general, pediatricians have prefaced convulsions with soothing adjectives like simple or benign and shunned the word epilepsy. But the benignity does not depend on its name, but on the severity, like a duration, presence of apnea, whether it is focal or generalized, singular, multiple. So this is William Gordon Lennox. Which of the following is not true about febrile seizure? Febrile seizure may increase the risk of Tourette syndrome. Febrile status is associated genesis of mesial temporal sclerosis. Febrile seizure is not associated with SUDEP. Number of febrile doesn't alter the risk of subsequent epilepsy. So although they generally say febrile seizure is not associated, but there are case reports of association. So out of these 4 statements, C is not true. Which of the following is not a risk factor for recurrence of febrile seizure? Family history of febrile seizure, family history of epilepsy, fever seizure interval, peak temperature at time of seizure. Family history of epilepsy is not a risk factor for recurrence of febrile seizure. Rather, it's a risk factor for subsequent epilepsy. Which of the following are definite risk factors for subsequent epilepsy in a child with febrile seizure? Neurodevelopmental disability, more than one complex feature. These 3 and 4 are not definite risk factors. So the answer is 1 plus 2, B. Which of the following does not prevent the recurrence of febrile seizure? Phenytoin, carbamazepine, oxcarbazepine. Phenobarbital is known to reduce the recurrence of febrile seizure. Yeah, this is a forest plot from a systematic review on febrile seizures. Intermittent oral clobazam at the onset of febrile seizure to prevent may be advisable in only one situation according to American Academy of Pediatrics, that is heightened parental anxiety. Expand JEFS plus. There is some confusion about what G stands for, but ILAE clearly says it is genetic epilepsy with febrile seizure plus. EEG is more likely to abnormal in the following settings except younger child, as madam has told in her talk, neurodevelopmental abnormality, complex febrile seizure. All these have a higher chance of EEG being normal. A family history of febrile seizure does not confer any risk of EEG being abnormal. Contraindications for intranasal midazolam. If you read the leaflet of intranasal midazolam, these are all mentioned. Myasthenia gravis, narrow angle glaucoma, hypersensitivity benzalkonium chloride, which is a component of that solution. Even open angle glaucoma not on treatment. So answer is D. Which of the following is the commonest cause of febrile status epilepticus? We all know HHV, but is it 6A or 6B? It is 6A. following are genetic causes of fever-related epilepsy. All these three genes, SCN1A, PCDH19, POLG1, are associated with fever-provoked or fever-related epilepsy. We are not talking about febrile seizure. It's a fever-related epilepsy. They can provoke seizures with fever. Which of the following is not a treatment option during the acute stage of fires? Ketogenic diet, cannabidiol, vagal nerve stimulation, anakinra. So vagal nerve stimulation is not during the acute stage, rather it can be used for the post-fires epilepsy. A 2-year-old child with a past history of 15 episodes of febrile seizure till now, born of a non-consanguineous parentage, has mild speech delay, now presents with afebrile seizures, MRI brain EEG is normal. Which of the following is not a drug of choice? So we are discussing about a kind of sodium channel mutation, SCN1A. So in SCN1A, we know sodium channel blockers are not advisable, like lamotrigine. 10-month-old typically developing baby, fully immunized, presented with fever, right focal seizure for 10 minutes. So it's a prolonged focal seizure. Identify the correct statement. I will do MRI brain with the epilepsy protocol. 7-year-old child has febrile seizure from the age of 1.5 years, 10 episodes till now. She also has myoclonic jerks, family history of febrile seizure in the fibrilling. So the preferable term is Jeff's plus. So 7-year and family history is also positive. Which of the following vaccine is not associated with febrile seizure? Pneumococcal PCV7 is not associated. All the three are associated. A 3-year-old girl with GDD, recurrent focal febrile status, now has myoclonic seizures. EEG is given below, which is the correct statement. This EEG's background is quite okay. It is just showing multifocal spikes. So it is not hypsarrhythmia or any other epileptic encephalopathy, which is non-specific EEG pattern. So you know phenytoin doesn't work in Dravet syndrome. So this is not for ACTH or Vega button like that. It's not hypsarrhythmia. So the answer is genetic testing can be done for precision medicine. For example, if it turns out to be SCN1A, you can prefer drugs like valproate, levetiracetam, Topiramate, or Clobazam. I think that's the end of the questions.
Okay, great.
So,
Ranjit, can you announce the winner?
Yeah. So can you see the summary slides, sir, of the quiz?
Yeah, now we can. You can zoom up a little bit more. Yeah, we can see it. Yeah.
No, I think it is. Yeah, now it is perfect. So it seems top 4 places are occupied by pediatric neurologists.
So that means your questions were good.
Yeah. So don't know the names of these persons, but Kona is Dr. Ramesh Konaki. He said it there now. So the first place among the pediatricians or pediatric trainees, it goes to Arunath. He is from University of Colombo.
Okay, great. Congratulations. And
we have an international winner. So the next prize goes to Sushma. She is a senior resident in pediatrics, completed 1 year back from JIPMER.
Great. Dr. Sushma, congratulations.
Third place goes to Akash. He is from AIMS. Whether he is
Dr. Akash from AIMS.
Yeah, he is a AIMS JR. His name is Akash Mahesan. He's an JR from AIMS.
Great. Congratulations, Dr. Akash. So it's a great show, and it is a proud thing that AOCN is organizing this kind of a quiz to motivate all the residents. Dr. Rekha.
Just sorry. Just click the questions button, please. Sir.
Which one? Questions.
The questions, yeah.
So
and to the side, if you just go to the right side a little bit, yeah, we can see your correct and incorrect, what percentage, which question has been answered the most. Just one little bit of fun there.
So it seems.
Which was the easiest, which was the toughest?
The question in the image below, that question number 4 was the easiest one, it seems. 54% is answered. And the forest plot, 60% have answered. So rest all, like it ranges from 10% to 30%.
Okay. Thank you, Ranjit, and thank you, Dr. Ram. It was a great show. Hope all of you enjoyed. And I would also thank Dr. Rekha Mittal ma'am for delivering an excellent talk. And we congratulate the winners, and you will soon, only the first prize winner gets the gift. The others will definitely get the certificate of appreciation, which we will get through the AOCN. Dr. Rekha, ma'am, do you want to?
Can we have the email address of the winner?
Yes, ma'am. Yes.
So anyway, thank you, Dr. Ranjit. Thank you, Dr. Kaushik. Thank you, Dr. Ram, for organizing this quiz. And I think it was a great.
Yeah, thank you very much.
Talking to everybody.
Thank you very much, and wish you all a good night. And thank you very much from AOCN. See you, all of you, next Friday. Thank you. Bye.
Thank you, ma'am. Thank you.